Welcome to Canadian Justice. I'm Christine Van Gyn. Today we're talking about a proposal to take away the right families have to give consent before a patient can be taken off life support. What happens if that choice is instead left up to doctors? We're also going to be looking at what happens if two people enter the hospital at the same time with equally critical conditions. Which patient gets the last bed? These are the real situations we may need to face if hospitals are overwhelmed with COVID patients. Right now, these situations are governed by Ontario's Healthcare Consent Act. This law requires that doctors get consent from a patient's family before withdrawing life support. A doctor can't take a patient off a ventilator if that patient's family objects, even if the prognosis is grim. But the Ontario government has now been asked to suspend this law. Hospitals have also been told to triage critical patients. Hospitals have been told to give life support priority to patients with the greatest likelihood of surviving whatever it is that brought them to the hospital. But if they're already on life support, they can't be removed unless their family consents. Should this law change, or is it necessary to protect patients? Today we'll be digging into these questions and more. We'll be joined by Miriam Shanuda, a lawyer with Arch Disability Law Center. Miriam, thanks so much for joining me today. I want to get right into it with this question about consent for end of life. You know, if there's someone on a ventilator in an ICU and they have no prospect of recovering, why shouldn't they be removed from that bed and the bed given to, you know, say a 20-year-old who comes in with critical COVID and needs the respirator? Why shouldn't that happen?
So thank you for having me, Christine. I think obviously you ask a question that's the bottom line that everyone's trying to get the answer to. And, you know, to answer this straightforward, we're not saying that that shouldn't happen. What we're questioning is, how are those decisions being made? What assessments are being used? Are those assessments inherently discriminatory? And the second part is whether consent can be suspended. And we take the position that it should not be. So it's not about two people at the hospital presenting with similar symptoms and then having to make a decision about one over the other or prioritizing one over the other. It's really about how those decisions are being made, and are they being made equitably? So, and one interesting thing is that a lot of times we start off this question with all things being equal. What I think is important to note here is that most of us don't appear at the emergency room or ICU on an equal basis. We know that COVID is affecting disproportionately persons with disabilities, elderly persons, racialized persons, and they will then be disproportionately affected by any triage protocol, deprioritization for critical care, and of course, any suspension of the HCCA.
So do you think there are constitutional problems with the proposal to suspend family consent for withdrawing life support?
I think there's potential constitutional issues. I mean, off the top of our heads, I think we can think about Section 7, of course, as well as Section 15.
And that would be Section 7's right to life, liberty, and security. Section 15 is equality.
That's right. You know, one of the seminal landmark decisions in this area is Rasuli, which was decided by the Supreme Court in 2013. Interestingly, the Supreme Court sidestepped any constitutional issues and rather approached it from a statutory interpretation perspective. But I still think the Supreme Court decision informs the approach that should be taken in interpreting the HCCA and applying the HCCA. And I think any contemplation of the suspension of the act must happen in public and must pay attention to any constitutional challenge vulnerabilities.
So just quickly, was the disability community consulted about this at all, this proposal?
For the suspension of the Healthcare Consent Act? No. We were not. There was a vague recommendation made by the bioethics table to the government in September. We received a proposed framework that was 36 pages long that included that vague recommendation, which said something to the effect of any deviation of the HCCA should be brought about by an emergency order. But we were not consulted on that at all.
Okay, it's very troubling. All right, we'll be right back to pick that back up after we have a commercial break. Welcome back to Canadian Justice. We're discussing what laws apply when ICUs run out of life support beds and how physicians decide which patients get life support. Let's talk now about the new triage system for critical patients. If two people enter the hospital at the same time with equally critical conditions, how should we, as a society, decide which one gets the last bed?
So again, obviously a very complicated question. But, Christine, this pandemic has exacerbated and brought into stark focus the inequities and disparities experienced not only by persons with disabilities, but persons from other marginalized communities, racialized communities, Indigenous persons, the elderly. And any triage protocol that has been developed, and in our discussions with the bioethics table, it's very clear that the drafting has been very siloed. So we're looking for a very simple, or not simple, a straightforward, efficient answer to what is rather a very complex question. And one thing that's really been ignored are the social determinants of health. And we can't, again, look at each and every patient that presents at the hospital during COVID as having presenting equally, because they're not. We have things like you said, age. We have the socioeconomic status, where you live. All of these things inform whether or not you're going to need care and how you present for care.
And those things also, they impact how likely you are to survive 12 months after you enter the hospital with your critical condition. I mean, that's inherent in some of those conditions. So, is the protocol, the triage protocol, inherently discriminatory?
It is discriminatory, and we've heard the argument that it has to be discriminatory, and I understand that. By nature, it has to pick one person over the other. However, in saying that, it should not be discriminatory based on protected grounds. That's just not something that we can allow easily. We also have to be cognizant of the fact that,
what do you mean when you say protected grounds?
So protected grounds that are codified in Section 15, equality rights of the Charter, as well as protected rights that we see, for example, in the Canadian Human Rights Act, as well as the Human Rights Code of Ontario.
So those would be things like age, disability,
gender, sexual orientation, ethnic origin, religion, and the list goes on. Of course, what we find is that some of these protected grounds come into play in this kind of scenario than others. So, for example, age, disability. What is not a protected ground, but should be a protected ground and does come into play, is also socioeconomic status. So persons who are lower income have actually borne the brunt of COVID. Persons who are elderly have borne the brunt of COVID. Same with persons with disabilities and racialized minorities. What I think COVID has done is provided a very sad but terrific example of compounded discrimination. So when we have persons who are more likely to get infected become deprioritized for care, that's just not a logical solution. So some have argued that really persons with disabilities and elderly persons should be prioritized for care.
And because right the triage protocol right now, the opposite.
Exactly.
So how do you respond to the concerns that some physicians have raised that triage isn't even possible without suspending consent to remove patients from life support because there just won't be enough beds to triage into?
Yeah. So with due respect, I don't think that triage is impossible without HCCA. I think triage is easier with the suspension of HCCA. And those are two very different things. And for the sake of efficiency or to make it less difficult to make these decisions, that is not sufficient to justify the suspension of such an integral piece of legislation that gives you and I and everyone else the core right to consent or have a decision-making agency in what happens to us when we go to the hospital or in receiving treatment. So I don't think it's impossible. One other thing is we're 12 months into COVID, and this is just arising now. If it was really impossible for triage to happen, why was this not raised in April, May, June, July of last year? So I don't think that position, with due respect, holds much water.
Yeah, and I certainly can't even imagine the fear that a person would have if they go into the hospital knowing that someone could make that decision for them, that the hospital, that an institution would make that decision for them. Miriam, thank you so much for joining us today. Your insight has been really valuable in this important topic that we really need to discuss out in the open. So thank you so much for joining.
Thank you, Christine.
Welcome back to Canadian Justice, where we're discussing the Ontario proposal on how to address COVID overloads in hospital ICUs and the possibility of ending life support for one patient in order to make that bed available for another patient. Joined by me now are two bioethics experts, Dr. James Downer, head of palliative care at the University of Ottawa and member of the government bioethics table, and Dr. Carrie Bowman, a bioethics professor at University of Toronto School of Medicine. Thank you both so much for joining me today. Now, Dr. Downer, I don't envy the position that you're in. As a physician, I'm sure you've had to deal with some really hard choices. But can you tell me why you support the proposal to suspend family consent for removing a patient from life support?
Well, I think you have to take a step back and understand what is the purpose of healthcare and what a situation we would be in if we were faced with an overwhelming surge in demand for critical care. If you're in a situation where you literally have more critically ill people than you have critically ill resources, someone is not going to get critical care. That's just a simple mathematical fact. We're going to do everything we can to try to make sure that doesn't happen. We've managed to avert it twice now, hoping it won't happen if there is a third wave. But if there is a situation where we literally have more demand than we have supply, really you have only a small number of options for how you can approach that situation. You either wait until all of your beds are full and simply turn away everybody else who comes to your ICU after that. You can do a process of random allocation, essentially randomly assigning who gets critical care and who doesn't. Or you can come up with a more rational approach where you try to prioritize people who have a higher chance of benefiting from critical care and surviving if they get it, as opposed to people who are very likely to die regardless of whether they get critical care or not. The argument is that if you're prioritizing resources for people who are more likely to survive, that at the end of all of this, you will ultimately be giving critical care to more people will survive, fewer people will die. Also doing so in a very rational and explicit manner with clear, explicit rules so that you don't run the risk or you try to mitigate the risk that triage decisions might be made on the basis of things that are not relevant for deciding on mortality risk, so that people will not be discriminated against on the basis of race, disability, et cetera. And those, I think, are really important principles that we're trying to apply.
Now, Dr. Bowman, can you respond to that? I know that you're opposed to this proposal to suspend family consent for end of life. Can you articulate why?
Yeah, first of all, if we're talking about the protocols themselves, I really, really get it. This has to happen.
You mean the triage protocols, right?
The triage protocols. So as we speak, and as other speakers have said, these two things are not the same, but they're quite related. Triage protocols really, really, as difficult as they are, have to proceed. If we don't have triage protocols, we may actually lose more people. As Dr. Downer has said, first come, first serve is really not going to work. But I have many, many doubts. The suspension of the Healthcare Consent Act, I think, is really extreme. And my greatest concern, being a person that has spent a lot of my life working in critical care units, wonderful people, wonderful, positive environment, is it can't be done well. And I would worry it would really be very inconsistent. That it could fracture. And it's an extreme measure to take this kind of protective constitutional right away from people. I think you're opening up some extreme vulnerabilities. I would be very opposed to it.
Now, Dr. Downer, I think Dr. Bowman is right. It's an extreme measure, but is an extreme measure warranted if this is an extreme situation?
I want to clarify. I think if you're proposing to do this in a disorganized manner with no rules or criteria around them, then I would agree with Dr. Bowman. I think that would be a very bad idea to try to sort of have people make bedside decisions based on whatever they can see around them without any guidance or consistency. I think is a very bad idea. What's being proposed in this situation is, in a case of triage, and this is consistent around the world, is that you're simply applying the same criteria to every critically ill person, whether they're already in the unit or simply arriving at the unit de novo. You're applying consistent criteria. In fact, I would say it's very important to include this as a part of a triage protocol for a variety of reasons, the most important of which is that it actually enables you to delay and potentially never initiate triage. So if, for example, if I know that once somebody is in the ICU, I cannot withdraw and I can only triage at the point of entry, I actually have to start triaging when I still have empty beds. There's no point in starting triage when you have no beds left. If I know that there is the option potentially to withdraw, if I have to, then I can continue offering critical care right up until the very last moment, until literally the last bed is full. And if I'm withdrawing or if I'm limiting critical care in any way, I'm doing it in a highly consistent manner and only as much as I have to.
Thank you both so much. We're going to come back after these commercial messages. Welcome back to Canadian Justice. Now let's jump back into it on this discussion about how we decide which patients are prioritized if hospitals and ICUs are overwhelmed. Now, Dr. Downer, everyone believes that all human lives are of equal value. Is triage asking us to value some lives over others?
Actually, I would say it's exactly the opposite of that. If you do anything other than a prioritization on the basis of mortality risk, you are in effect valuing some lives over others. So if I, for example, if I have 5 ventilators available, and if I use those 5 ventilators on five of one group of people and I only save 1 life, and then I use those 5 ventilators on a different group of people and can save 4 lives, if I'm valuing all lives equally, it would make sense to be using the ventilators in the second case to try to prioritize it for people whose lives I can save. The only possible justification for not doing that would be as if you place a higher value on some lives than others.
Now, Dr. Bowman, we all want to achieve the same thing here. We want to have the most people survive. So what's the ethical framework we need to use when deciding how to achieve that goal?
Look, I actually think the Ontario framework is one of the more progressives. I think it's a good framework, but I still cringe from an ethical point of view, because we will find many of the most vulnerable people. And in fact, vulnerability aligns with medical fragility at times, and those are the people that wouldn't get support. But I really do believe we have to do this. My greatest concern is the suspension of the Healthcare Consent Act. If we look at this very pandemic and we look at how the hospitals, 6-7 weeks ago, were handed vaccine rollouts, there was clear protocols. They pretty well did whatever they wanted, and they did not adhere to the protocols. You had IT staff, you had people that hadn't been in the hospital in 8 months receiving vaccinations, and there you had protocols that were pandemic related. I fear something like this could happen again. I'm not saying people wouldn't take it seriously, but I've seen how these things play out. I would also add, shifting from patient-based to a utilitarian, what's best for the largest number of people. When we shift our ethical platform, it raises questions as to whether we're really committed to those ethical principles or not. And I see them as constitutional.
So, Dr. Downer, some health policy advocates say that the solution is a better healthcare system and more resources. So how do you respond to that? Why can't we just transfer patients between hospitals when we're short on beds?
We're doing that anyway. That's exactly what we're doing. The triage is what you do at the very end. Once you've mobilized all of your possible resources, your staff, you've taken your operating room ventilators and are using those to ventilate people, and you've moved everybody around as much as you possibly can. It's about having a plan at the end. And I think Dr. Bowman brings up an excellent point about what happened with the vaccinations, is that you had a plan, but people didn't follow it. That's not an argument against having a plan. That's an argument that they really should have had a plan that was followed. The concern is if you don't have a triage protocol like the one we're describing, and you allow people to essentially make decisions on the ground without any further guidance, that is what happens, right? So I just want to be very clear about that.
Yeah, it's in my view, more resources is always the answer, but more resources isn't exactly possible, by snapping your fingers. And we have to face some of these choices imminently and possibly in a third wave. So I want to thank you both so much for joining me today. It's been a fascinating conversation, and I think it's one that needs to happen out in the public. So thank you so much for your contribution today. And I love chatting with both of you. We've heard today about the untenable situation physicians and patients may be placed in if hospitals run out of ICU beds. I don't envy any of the physicians who are placed in these situations or the patients. And I have no doubt that every person working in frontline healthcare has the same goal, which is to save the most lives. What's the right policy to achieve that goal? What's the ethical framework we need to look at when deciding how to allocate finite and dwindling healthcare resources? These are incredibly difficult questions to answer, but it's a conversation that needs to happen publicly. All human life has equal, inherent, and incalculable value. We've heard today about some of the concerns, both legal and equitable, about what it will mean to triage critical patients when resources are limited, and what it could mean to move one patient off life support in favor of another patient. We've also heard the perspectives of physicians and ethicists tasked with making these impossible choices. How should we as a society make these difficult choices? Should the policy withdrawing consent for pulling the plug on life support be suspended? Or does this violate the rights of patients? You be the judge. I'm Christine Van Gyn, and remember, a freer Canada starts with you.